Okay, I think we're going to go ahead and get started this afternoon. Thank you, everybody, for joining us. My name is Tanya Dorf-Bruner, and I'm the Executive Director here at Oral Health Kansas. I'll be the moderator for today's webinar. This afternoon's webinar is about approaches to oral care for children and youth with autism. Before I introduce our speaker, though, I'd like to cover a couple of housekeeping issues. First of all, we'd like to note that this webinar is being recorded. We're going to be encouraging and accepting questions from the audience during the presentation. To submit questions, please enter them. We'll go back to one slide in just a second. Please enter them in the question and answer box on the right-hand side of your screen. These questions will be sent directly to our office here, and we'll be able to read those and share them with Dr. Friedman. We will stop at 3 different points throughout the webinar and ask for questions. Maybe we'll go back one slide just so that you can see. If you have any technical assistance problems during the webinar, please, I encourage you to email me at tdorf@oralhealthkansas.org. Julie Parnell in our office is running the PowerPoint and the webinar, so I'll have a separate computer ready for any technical assistance questions you may have, so please feel free to email me. I think at this point then we're ready to, we do have a slide here we want to quickly kind of share with you that we shared this last week, but we want to share again just kind of a history of the commitment that we have in the state of Kansas to the oral health needs of children and youth that have special health care needs. We've been pleased that it's been an important focus and emphasis in the state of Kansas for years, and we've been pleased to be a part of that. There is a sedation dentistry services available now at Grace Med, which is something new and very exciting. We've been able, through Oral Health Kansas and our partners, have been able to design and distribute oral health educational materials. Together we work on coordinating workshops throughout the state. There are lots of opportunities for oral screening and fluoride varnish for children and youth with special needs. And maybe the latest in the last couple of years, we've been able to incorporate dental hygienists in several specialty clinics for children with cerebral palsy, cleft lip, cleft palate, spina bifida, and there might be some other additional clinics we are able to include that in the future. So we're excited about what we're doing in Kansas, and we're even more excited about learning more today about what we can do to meet the oral health needs of children and youth with autism. So I'm pleased today to introduce you to Dr. Clive Friedman. He was born in Johannesburg and has trained and worked in South Africa, Israel, the United States, England, and Canada. He obtained his specialty in pediatric dentistry in New Orleans and has a special interest in persons with special needs, with their behavior, prevention issues, education, and wellness. But first and foremost, Dr. Friedman is a private pediatric practitioner. He offers a range of services for children and adolescents at his London, Ontario clinic. And to honor his commitment to stay current in the practice of pediatric dentistry, he conducts active research in his office. He teaches at both the University of Toronto and the Schulich School of Music. Possibly. He's such a well-rounded person, it might be there too. For the Schulich School of Medicine and Dentistry, he's been the president of the International Association of Disability and Oral Health and of the Academy of Dentistry for Persons with Disabilities. Dr. Friedman is frequently invited to lecture both locally and internationally on risk assessment, behavior, minimum intervention dentistry, autism, special needs, abuse, and new approaches in dentistry. And we're proud to say many of his articles have been published in dental and special needs journals internationally. We're excited to be able to work with Dr. Friedman today, and we're going to turn the webinar over to him at this point. Okay, Dr. Friedman, whenever you're ready, feel free to get started.
Okay, great. Thanks a lot. I guess I'm ready to go. Welcome back to all those. Welcome back to all those folk who were here last week, and hopefully we don't have the same problem that we had last week. But if you do have a problem with seeing the slides or hearing anything that I'm saying, please email so that we can catch it a lot sooner than we did last week. So welcome again, and today we're going to be talking about autism spectrum disorder and treatment of individuals with autism. Marcia has already sent you a huge amount of material, And right off the bat, I want to let you know that a lot of the material that she has sent, I will not be covering any of that material. The expanse of autism is quite huge, and it would take a whole day to really cover most of the material. So I'm going to, in some sense, cut to the chase and deal with some specific issues that I find specifically challenging and interesting with respect to autism spectrum disorder. So autism spectrum disorder really provides us with quite a challenge of our beliefs, our attitudes, our practices, our values. It's one of those disorders that perhaps is very different from many of the other areas of disability. But the truth is, the secret to working with individuals with autism is actually rather simple. It's about getting into their world. So it may sound simple to get into their world, but perhaps it's a lot more complicated and more complex getting in and understanding their world. And hopefully what I can do for you is describe some of the methodologies that will help you to get into the world of individuals with autism. So it really is more about understanding their behavior than actually managing it. So the objectives for today would be to expand on some of the topics that you have been sent, to discuss the neurobiological approach to behavior and interventions, and I described that I would do that last week with the individuals with Down syndrome. However, I will be covering it in more detail today. And then I'm going to provide you with some examples of interventions that work based on the basic principle of the neurobiological basis for behavior. Just as a reminder, I want to just remind you that autism as well is covered within the International Classification of Functioning. And last week I know you were not able to see this particular slide, so I'm going to replay it. And the ICF is really based on an integration of two opposing models of care, the medical and the social model of care, of which I described in more detail last week. And with respect to autism, if we have a look at the different domains, then any one of these will impact the quality of life of an individual. So because ASD or autism spectrum disorder is such a wide-ranging spectrum, an individual can fit anywhere within this model, and what we do and how we do it is going to be impacted by where they may fit into this model. So the definition of disability, as I'm talking about it today then, is the outcome of the interactions between individuals, their psychological, physical, and social environments. And essentially the cause is irrelevant. Not unlike the slide that you see, which is of the polar bear, that is intensely affected by their environments, as well as by what it is that our culture does in the environment. Just as an aside, any of the slides that you see of the natural habitat have all been taken by myself, and I actually use the natural world a fair amount with respect to describing some of what happens in our world. So when we talk about environment in the case of individuals with special needs, here's again a picture of an area in the northern Arctic actually, and the environment is classically impacted. These particular birds can only catch those fish when the ice moves. The complexity of the ecosystem is very interesting in that it continues from the fish all the way through to the polar bear. And equally so, when we talk about individuals with special needs, all we have to do is take a look at that environment, and dependent on where an individual may live, what the philosophies are with respect to how autism is approached within that environment, a particular child is going to be subjected to very different kinds of environmental attitudes, if you will. So autism can, or kids with autism can be treated with any of the processes that you can read on the screen. So for Teach, for example, is a program that is taught primarily in Japan. Applied behavioral analysis is something that is taught primarily here in London, Ontario. And sensory integration can be something that is highly applied in places like Argentina. So an individual can be exposed to a huge variety of different environmental processes or learning programs. And our job really is to try and determine which one of these an individual is following. It goes back to the concept of knowing who we are dealing with. Carl Jung in 1927, as early as 1927, spoke about how we cannot really understand the psychology of the child if we regard that individual as a subjective concern of the individual alone. And we really have to take into consideration their relation to others, which really comes to the whole concept of ICF. At this point in time, I did want to take some questions from the audience. And if I don't have any questions, I wanted to just deal with some of the issues that I picked up from my perspective in terms of the Autism Network and some of the material that Marcia sent to you earlier. So, Julie, if you
we don't have any questions yet.
Okay.
So look forward to some in the next session.
By the way, if anyone does have questions as it comes up, please send them through and they will bring them to my attention. So for example, in the Autism Network, some of the issues that were brought up, for example, were brushing and the need to desensitize individuals prior to brushing. And I'm going to talk a little bit more about that in more detail later on. And they spoke about the need for children to open wide, for example, but my perspective is that we don't always want children to open wide. Sometimes it's better for them to have their teeth brushed with their mouth closed. They spoke about the need for consistent routines and for being able to brush left, right, upper, bottom, whatever. And my perspective again would be that the routine is important, but the process of brushing, perhaps, we need to be really careful about asking parents to be brushing for 3 minutes or 4 minutes or 2 minutes, especially with individuals with sensitivities. And I will go into that in more detail, and you will see why that is important and what one of the ways to work with that would be. They speak about the need for toothpaste. Again, there are sensitivity issues, and if a child doesn't like toothpaste, don't sweat it. Why use toothpaste at all? There are lots of different flavors of paste that one can use. So for example, MI paste made by GC has melon or strawberry or tutti frutti, and sometimes the kids might enjoy that more than the actual taste of toothpaste. Power brushes. The Autism Network speaks about power brushes, and they discuss that the child should first learn how to use a manual toothbrush before a power brush. Again, I have a different perspective, and again, dependent on the sensitivities of an individual, we might want to change that. So let's move on to the concept of the neurobiological nature of stress and the biological aspect of what happens to kids and individuals with stress and with autism. I spoke about this slide last week, and I think that some of you were not able to see the slide. But if your patients are anything like my patients, 99.99% of them have an anxiety towards dentistry thanks to our culture. And individuals come in expecting that automatically dentistry or dentists are going to hurt them. So before folk even come into our offices, their anxiety is increasing. So what is our response to trauma? Again, I come back to the natural world. And here's a picture of a kill where those lions killed one of those baby zebra. And the zebra that you see in the background are basically watching these lions decimate one of their kids. Now I actually photographed this in Africa. And what is interesting with the whole response to trauma or to stress is the activation of the fight or flight response, or the activation of what's called the ALPH axis, or the autonomic limbic hypothalamic pituitary adrenal axis. When that axis is activated, what ends up happening is our whole body is sent the hormones of cortisone or adrenaline, which goes to our muscles, which say, run, get the hell out of here. And that is, generally speaking, the response that we have to some kind of a stressful circumstance. What happens in the animal world is, certainly, yes, those zebra are going to run as fast as they can, but once it's over, they get to watch that process. They no longer are anxious, and they let go of that anxiety by incredible trembling. And what happens with us humans is that we actually don't let go of some of that issue, and where we have chronic stress builds up in our systems to such a degree that you have an incredible wear and tear on the tissues and organs in our systems. So what is described then is the process where our bodily functions meet daily challenges of fight or flight responses. It operates through the nervous system, which is that LHPA axis. And when we have normal kind of responses to it, we can cope with those responses in daily life. Where we have an excess or prolonged load in terms of stress to our systems, we end up having chronic mental or physical disease. So an individual learns what they're capable of or what they're not capable of. Now, what's interesting is in individuals with autism, sometimes that, how I understand the neurological development of individuals with autism, is that the neuronal connections actually do not get what they call pruned appropriately. And sometimes those sensitivities and those responses to stress are not dealt with in the same manner as they are dealt with you or I. So let's have a look at an example of what I'm talking about in terms of the flight or fight response with children or kids with autism. And this really applies to any aspect of when that LHPA access is triggered. So anytime an individual is in that place of hyperarousal, let's just watch this video to see an example of what might look like hyperarousal.
We're going to you're going to sit in the chair by yourself, or we're going to get Daddy to put you in the chair. Can you get into the chair by yourself? No? Okay. So Daddy, I want you to put him in the chair for me, please. Mom. Oh, Mommy's not here today. Okay, so Daddy. Daddy, I don't want you to say anything because it may not be just brushing. He won't feel anything, but that's not just brushing. We're going to be cleaning the tooth. Yeah. Okay. So Daddy's going to put you in the chair unless Jay wants to go in. Okay, Dad, put him in the chair, please.
So do you think that kid is in a state of hyperarousal or not? So we don't really have time for me to show you the full extent of some of this video material, and perhaps what the Kansas Authority can do is invite me down and then I can show you the complete video material and talk about how to deal with each of the individual situations. But what I want you to focus on, and the take-home message here, is the concept of hyperarousal. Anytime an individual is in that place of hyperarousal, in that place of fight or flight response, in that place where they are wanting to run away, it is really useless to try and do any kind of dental treatment before that individual comes back to a place of what's called homeostasis or balance. Because what happens is that alarm center really is triggered and it goes to the primitive brain center and the amygdala. And the amygdala is the key component in our neurological network system that deals with fear. What's interesting is those individuals who have had very good attachment histories with their parents tend to deal better with that fear than those individuals who have not had good attachment histories. So with autism then, it's very hard to determine what some of those attachment histories are like. And the emotional experience that kids will oftentimes have related to something completely alien to dentistry may in fact be triggered by something that we do in the dental circumstance. So a lot of what it is that we do is not always only associated with the oral cavity, but can psychologically be something that is a stressor or a starter, if you will, of something far greater than what it is that we may have imagined. So the limbic system actually records every neural experience, and it's this associative representational memory that drives behavior from a sensory level. So for individuals who have autism, who have sensory processing disorders, may lead to a misinterpretation of everyday information. So touch, sound, movement may not be interpreted like the average individual might do Again, I come back to that process of neuronal pruning, which I may speak to in a little while again. So past history of success or failure is absolutely influenced by our past successes and failures in similar circumstances. So what happens with a child when they first go into or first have an experience can so oftentimes be related to what it is that happens when they come into the dental experience. And a huge issue here for us to remember is that many times the parents may actually be in that hyper-aroused state as well. If they have their own fear, their own anxiety that they bring with them. And a lot of the dental literature actually speaks to that. But this speaks to the underlying neurological process by which that actually happens. So if we're dealing with an adult or a parent and the child who are in a hyper-aroused state, we have a major issue. Now the other aspect of this that I wanted to point out is hypoarousal, or the freeze response. The freeze response is where the body just cannot move. If you've ever had a dream where you've been having a real nightmare and you wake up and it's like your body can't move, you're in a freeze response. The freeze response is no different to the fight or flight response. It's the same process in some ways, but sometimes a lot more difficult to work through, especially in the dental circumstance. And I'm not going to go through that in any detail today, but it's something that is very interesting. So this brings us then to how do we get into the world of the individual with autism. And Marcia did send you some information through which talks to a pre-appointment questionnaire, getting that information from that individual prior to them coming in. And I've actually sent to her a copy of the material, the pre-appointment questionnaire that I use, that you are most welcome to use, that she can send through to you should you like it or want it. Just send her a message and ask her to send you a copy. But the pre-appointment questionnaire with respect to individuals with autism, I think, has to be far more advanced and far more detailed than our normal generic questionnaire with respect to individuals with disability, because we're looking at so many different and more complex processes. So, for example, the support system. What kind of school system does this individual see? Is the child being seen within an intensive behavioral program or IBI, or is the child homeschooled? What is it, or how is it that that child is functioning within their environment? With respect to communication, is there a particular communication methodology that's being used for that individual? Today, the iPad app has a large number of fabulous apps where individuals will communicate through their iPad, and it's helped communication tremendously. What, for example, is the manner in which this individual socializes? How do they react with peers, with adults, with the support system, with the overriding support system with respect to how they're assessed within their support system? Are they responsive to instructions? Who are they most responsive to? How do they do with haircuts, for example? Reinforcers. What does the parent, the home, the school use to reinforce this particular individual? And they vary dramatically from institution to parent to school systems. It could be something like favorite toys, and oftentimes individuals with Down syndromes are reinforced with food. It's important for us to know that information. and not only know the information, but what specifically and when it is done. The sensory profile for an individual. Here we're talking about all the 5 senses, and we're not only talking about what is it that they are sensitive to, but we're also talking about what is it that makes it worse or makes it better. Dietary issues. Individuals with autism have huge dietary issues. Many of them would be eating very specific foods, sometimes only carbohydrates, sometimes only vegetables. There's a large body of research at this point in time that identifies a relationship between diet and autism. And again, we have an environmental issue and belief systems. Where does that parent and where does that child fit within that dialectic, if you will? And perhaps even more important when a parent comes in to us within the dental office is what are their expectations for us with respect to their child? What are their goals? And if they don't have expectations or goals, it's clear for us, it's an important place for us to begin in terms of identifying, well, what are our expectations or our goals? What is it that we as the dental office can expect to do? And then what is the parental perception of what success will be? I think these are important communication issues that we need to have a look at when we're talking about what is it that we're doing. Another important question I think that we need to ask is that about anxiety, that hyperarousal space. Is there anything that the parents or the school system can do or do in terms of getting that patient or that person back to a place of homeostasis, back to a place of balance that will help them then move on? And it's that place of balance where we always need to start. And I'm going to be repeating that a number of times. So when we talk about sensory processing disorders, we speak to the issue of what happens when an individual modulates that, or how they modulate that process. So for example, if an individual is hypo or under-responsive to a particular sensory position, if you will, they'll oftentimes require much stronger inputs to register that sensation. So for example, diet. If an individual is hypo-responsive, under-responsive to a particular taste, sometimes in order for them to taste something, they need something much more intense. And I know some nutritionists who actually use, for example, Tabasco on all the food to allow the child to get a sense of taste to improve the diet for an individual. If they're hyper-responsive or over-responsive, a very slight input will cause an extreme reaction. So noise, for example, very slight noises, just the sound of the light in your waiting room could put an individual over the edge. Then when we talk to more physical or somatic responses, individuals, for example, are sensory seeking, their behaviors are driven by the specific need for an input. So they are really seeking deep pressure, for example, or they need very strong hugs, or they need a lot of weight on their bodies, and it allows them to settle down prior to you being able to go in and do any type of treatment. And then there are those individuals who are sensory aversive, where there is an overriding avoidance of a specific sensory input, for example, touch. So they may be extremely avoidant to light touch, but really seek deep touch. So you can see the dialectic of autism here is huge, and knowing what that person who walks into your office has is important. And for the parents out there, having an understanding of what it is that we're looking for and the information that would be useful to use is very important. This British psychotherapist clearly speaks to this particular issue, and the challenge for us is to help attune our own senses into the psyche of the person that we're working with so that we can listen and comfortably get into their world. So I'm going to give another opportunity for questions at this point in time, and while you are thinking of any questions, what I'd like you to do is just to stop and think for a moment of some of the methods that you have already used that may help, or that you find that you use in decreasing that hyper-aroused state of individuals when they walk into your offices. If I don't have any questions, I'm just going to continue. Things like social stories, what do you do with your environment, what are the classic behavior interventions that you might use, for example, tell, show, do. Which one of these do you currently use? A lot of individuals who possibly work with autism right now are clearly understand the use of social stories as a way of decreasing that hyper-aroused process of individuals, allowing them to arrive at your office in a more balanced state. And what I have here, for example, is a social story that is real live video taken from the perspective of what a young child will see. So it's at their level rather than the level that would happen when we see it as an adult. So how does a child walk into our office, and what is it that they see? So this video was taken and is available to my patients on my website. So that a parent can actually show their child prior to coming in what they may see.
How are you this morning? Taxi, we'll let you know your date.
The environment, I think, is a very important part of what an individual sees when they come into an office. And my philosophy to this has changed over the years. That video goes on to actually show the beginning of a program, the Determined program that was first described by David Ticini. And I'm not going to go through any of that in any detail, since that material is readily available to you and can again be made available to you by Marcia. But I've actually shifted dramatically from that time where I believe that, again, it's about what is it that's going to bring that individual to a place of balance. And if it is the determined program or successive approximations or the intervention of desensitization, then that's what needs to be used. Is it something else that needs to be used? That's what needs to be used. So the more information we have from the individual, the better. Let me get to a little bit more on sensory awareness, because the sensory issues are huge with respect to individuals with autism, and any of these can be used for helping the sensory issues with respect to individuals with autism. So I'm going to talk a little bit more about sensory integration and music therapy. But equine therapy, for example, is horse therapy that's used with individuals in Argentina for kids who are autistic prior to going to the dentist, that helps them come to a place of homeostasis. Craniosacral is another aspect, and I have some video. I'm not sure we'll have time to watch that. In this book by Ramberg and Washburn in 1996, they speak about the need for very bold, aggressive management. And what needs to happen is the demonstration of extreme patience with individuals with autism and giving an intervention program that has ample opportunity to activate the neural process of plasticity that will allow those individuals to change. So it's back to the issue of the neurons, the pruning, and how those individuals learn, and knowing how each individual learns from their own perspective. You might ask why we use sensory integration. Because of the huge impact of the sensory hypersensitivity, truthfully, we as a service provider cannot intervene at the level of how an individual presents to us. It's what I was saying, we cannot intervene in that place of hyperarousal or in the place where an individual is in a freeze response. We really have to meet the child or engage them where they're at first before we can continue with providing them with any kind of process. So if their sensory needs are not recognized and they're denied, so then they're not going to be able to settle down and allow us to do anything. So an individual who, for example, has got extreme sensitivity around the mouth, if we don't deal with what is happening with that sensitivity and we try and go in and examine or brush, they're going to react and prevent us from wanting to go in. So I spoke briefly about trigger points last week that Rodolfo Castillo-Morales speaks to. And there's specific trigger points on the face that if we can identify here in numbers, that will oftentimes help decrease sensitivity for an individual. So let's have a look at what I talk about when I talk about sensory integration prior to treatment. If you think about those neuromotor points that I just described by Castillo-Morales, what's happening here is this particular individual with both Down syndrome and autism is having very deep tissue massage done in the area of those trigger points prior to us going into even looking at her mouth. So before we even ask her to open her mouth, we may spend 5 minutes or so with deep tissue massage in those particular neuromotor points that will help desensitize her or decrease her triggering when we actually go in to look at her teeth. This is an individual where I actually built up her posterior molars as well, and due to extreme grinding. And on completion of grinding, the parents reported that once we built up her molars, all grinding ceased. In this next video, what you're going to see is an individual with Down syndrome and autism that the only way that I could get the child from a place of hyperarousal to a place of homeostasis or balance up until the point that Dr. Martine Anakin, who you will see in the video, was working with him, was with deep sedation. Now, take a moment to watch this video.
Because that's quite new.
Yeah, quite new.
Could you give the glass to Mommy? Could you give your glass to Mommy? Yes. No. Yes? You want to keep it? You want to keep it?
Again, I'm not going to let you see the full video here to, again, encourage you to invite me down there for a much more intensive session. But what you're very briefly seeing here is the right brain, left brain attunement process using music therapy, using mimic neurons, using deep pressure massage, all of which allows for intense presence or alignment with the psyche of the individual that we're working with. So it's an attempt to get into his life, to work with his motor sensitivities before even beginning to have a look at his dentition. So the detail with respect to the neurological intervention with this particular child was absolutely fascinating for me, and it is this one piece that actually turned my whole practice around with respect to the approach that I have with individuals with autism, from a place of using sedation or restraint or papoose boards to a place where I seldom use, or if ever, and I actually do not recommend the use of papoose boards at all, unless an individual really looks for deep pressure and weight and the parent requests that of us. But what you're seeing here very briefly with Dr. Anakin is the implementation of a number of different neurological processes that helped this young kid come to a place of homeostasis before we were able to continue with him. So just so that you can see, 1 year later, this is the same child. Again, we're doing the facial neuromuscular massage, and he now is essentially functioning like any other kid in the practice, and we've been able to move from a place of sedation to a place of complete homeostatic alignment with the rest of dentistry. Music therapy. This young lady, and it's not always a success story, took me 13 years to get to the place where we were able to work with her. And it was only after intervening with intense music therapy, both within the office and prior to office procedures as well as at home, that we were able to get treatment with her without any kind of drugs or restraint. I'll let you just watch this for a few seconds. Again, you will notice the environment that that individual is being treated in, completely outside of a dental office environment. We actually treat her in a more like a living room area in the basement of my office, because she so reacts, or she has such an amygdala reaction to the smells and the tastes and the sight of the dental office itself. Here's another example of decreasing sensitivities of hearing for an individual. So this is a listening tube, and this young boy screams very loudly. And by using a listening tube and just very, very gently or quietly talking into that, helps him to overcome that hypersensitivity, hyper reaction to noise levels. This is a video, and I'm not going to continue to show it in detail so that there is some time for questions, but this is a video of a young, well, he's not such a young boy anymore, with autism and some other disabilities, where we used craniosacral therapy for him prior to any intervention. So the craniosacral therapy was what worked for him in terms of decreasing his hyperarousal. And it did a number of other issues, and it's not always easy to do this kind of intervention. This happens to be a sister who is a craniosacral therapist. And these were a number of the things that she noted that happened after she started with working with him. Decreasing sensitivities related to sight. What you're seeing in these pictures is the whole concept of fluorescence and the ability to decrease an individual's hyperresponsivity to the actual visual sensitivities. Again, these machines are not cheap, and although used in the hospital, I don't have one of them in my office, but it is something that is interesting that can be used, and these are used prior to anesthesia in our particular hospital to decrease that hyper-aroused state of individuals with autism. For those of you who are interested in reading anything on getting inside the individual, here are a number of very excellent books that have been written by individuals with autism, and probably you are familiar with these. And again, Marcia can send them to you if you don't have time to get to them. So very briefly, you can see how in 1 hour I've basically just skimmed the surface of the whole concept of the neurobiology and interventions and sensory integration and the senses, and what it is that we can or cannot do, and how we can intervene with individuals with autism. And hopefully it has enabled you to give you some ideas of what it is that is possible out there. But certainly within an hour, it really is impossible, and I do apologize for not being able to give you any more detailed information on some of the things, but at least you might have a taste. So thank you, and I'm available for some questions.
Thank you, Dr. Friedman. And I'm glad that you already in your presentation entertained the idea of an invitation to come and visit us here, because I think we may want to invite you here. We do have a few questions. I think we're going to take time just for one right now in the interest of time, and then make sure we do get answers to all the questions back to the people who asked them. You know, I guess I'm debating between a couple different questions. There's two of the questions kind of have a theme that is not surprising, and really is how do you find dentists who are open to looking at alternative approaches such as the ones you've described? And that's kind of a theme we're seeing in some of these questions here. Is there any advice you have? Is there a magic bullet?
I imagine those questions come from a parent.
I think they are, yeah. I see a lot of questions here from parents, yes. Yeah,
honestly, I don't know how you find dentists who are open to those approaches. I know that one of the authors in the Autism Network who wrote up some of the, Karen Raposa, has just written a text. Of approaches.
Dr. Friedman, are you there?
This knowledge is the first space to actually then ask the dentist, is this something that you would be open to doing, would be the way to go? Because a lot of the dentists are perhaps not even familiar with these approaches. And in some ways, it's the parents' right to advocate for bringing them to the dentist's perspective. I've learned a lot of these things from parents.
Wow. Okay.
I don't know if that answers it in enough detail, though.
Oh, no, I think that's helpful, because I was struck by the same thought that that not everybody has a Dr. Clive Friedman to go to, but we can work together to advocate to help to get more kids with dentists that understand these ideas. We will get the rest of the questions answered, and I apologize for running out of time, but we want to thank Dr. Friedman again for your presentation today. We hope you found it helpful, informative. If you do have additional questions or thoughts, we ask you to please consider sending those to us. I think Julie's going to put up a slide that lists her email address. And Marcia has just one more thing she'd like to share with everybody today. Hi, everyone. Thank you for registering. Thank you for being on this webinar. I did want to say that, first of all, Kansas has started an autism work group to figure out all the different ways we can help parents, educators, specialists in autism, child life specialists. So we will be coming out with some information on a regular basis, and we will use the emails of everyone who registered for the webinar as our source for communicating to folks. And then if you don't wish to continue to receive them, you can just let us know. We also will be sending out a brief survey on SurveyMonkey just to get some feedback from you, which we will appreciate you completing. And also, we have a list of resources, not only those that Dr. Friedman provided, but also we will have a list of resources from Kansas and from other organizations around the country. This is a commitment, I think, from all of us, knowing that every child, every adult deserves good oral health. And as Dr. Friedman offered to us, it's our job to figure out how to respond to each individual with what will work for them to have good oral health. Thank you very much for joining us. Thank you, and everybody have a nice weekend, and thank you again for joining us. Bye-bye.